when I was offered a VBAC with my history and stuff, I had a few doctors because I started with one doctor and I moved and ended up with a different doctor. So I had the conversation first time, by the way, with my doctor. The first visit right away, sat down and they were like, "You've had a C-section before. What would you like to do this pregnancy?" And I was like, "I don't know." I want to talk about my options. So what were they? Yeah. I was like, "Tell me what they are." So they were like, they were like, "Well, what's kind of your goals of this?" Cause I was like, and they did tell me I could change my mind, which was really nice. They were like, "If you want to do a VBAC, you can always change your mind as you're going along through pregnancy. We don't have to stick to a VBAC." And they also offered, I could pick a day and be like, "This is my scheduled C-section day. So we can try for VBAC, but if it doesn't happen, we're already planned and ready for the C-section," which was really nice. I did ask because I was like, okay, well, I don't want to go overdue was my major issue. Was I was really, really worried about even reaching my due date or whatever, which I was told we can have your C-section the day of your due date, or we can do it earlier. And then that can be your thing. And they were like, "But we really want you to go into labor normally, naturally, we don't want to induce or do anything like that unless you reach that point of like, you're already kind of like ready and we just need a little push or whatever." That's basically about it. And so I've heard a lot of people say like, "Oh, I don't want to get, Pitocin with a VBAC," but I do know from my own experience, the doctors were like, "We won't do it like for a VBAC, like especially with what you're looking for, what you want, we're not going to do that." So I wanted to ask you about that because I know you were talking about the different stuff. It's like some people get this confused thing of like, they're going to give me all these meds and do all this. And it's like, not really, because a VBAC is different than just a normal, like your natural vaginal birth. It's different because there's a lot more to look at. There's a lot more going on. So I kind of wanted to ask a little bit about that because I think people don't kind of understand it is a little bit different than just having your first time vaginal birth or vaginal birth after more vaginal births. Like they're different. So that's what I was just kind of wondering. I know my question probably didn't come together very well in there, but I'm wondering about like the inducing side of it.
Well, but with a VBAC, you don't have all the options open to you that you do with a normal induction. Like if I offer all of my patients, first baby or not, induction in the 39th week, just because there's evidence, a lot of evidence, ARRIVE trial, et cetera, that says that's the best time to deliver. So when we start getting to our 39th week, I offer every patient, I give them a copy of the trial and say, if you'd like to deliver in the 39th week, I know it's not something that you hear is a good thing. Induction has this like horrible, connotation, which it's all untrue. If I induce you or if you go into labor on your own, end result is you have to have enough contractions to have a delivery. So whether we do it or you do it, doesn't matter. But that's neither here nor there. For induction with a first baby, it all depends on what condition their cervix is in when you start your induction. We have a score. We look at how dilated are you, how effaced are you, or how short is the cervix, how soft is the cervix. Is the cervix moved to anterior? Like cervixes all start posterior. So if someone examines you and you're not in labor, they're reaching really far back for your cervix. But if you're in labor, it comes forward. And when you're ready to deliver, it's very anterior. And then we look at how far down is the baby's head. And we score all of those things and you get a Bishop score. That's what we use. And if your Bishop score is very low, like the cervix is just not doing anything, you're long and closed, not in labor, not feeling anything, then it's going to take longer. So we have things available to us like oral medication. We have vaginal medication. We have medication you put in near your gums and it dissolves. We have medication that looks like a tampon that goes into the vagina near the cervix and dissipates medication over time. Those are all prostaglandin types of medication, and those are all contraindicated in a VBAC. So you can't use those because it increases the chance of uterine rupture. So that's a whole category of medications we don't have available to us. So what do we have available to us for a VBAC? 3 things. 1, strip the membranes. Someone comes to the office, they're not really much dilated, but you can get a finger in the cervix. You can do a membrane strip that releases prostaglandins. And that is something that if you were about to go into labor on your own, that release may get it going. Does it put you in labor where that same day you go in the hospital? Rarely, but sometimes. It's not designed to break your water. It's not designed to do anything else, just release prostaglandin. So you have a membrane strip. You've got balloons. There are all different kinds of balloons that we use now. One is a Foley balloon that we usually use when we drain someone's bladder. One is called a Cook balloon, which has 2 balloons actually, where you put the balloon into the cervix. It blows up in the lower segment of the uterus, and one blows up in the vagina. It looks like an hourglass kind of thing with 2 balloons. And you put a lot of fluid in it. It's mechanically dilating the cervix. I love those because there's no medication in it. It is just a mechanical dilator, and it can stay in there for about 12 hours or more sometimes. And it either falls out when you're 3 to 4 centimeters, or at the end of 12 hours, we deflate it and take it out. And if you have to do that, for me, that just put you down a notch in the likelihood that you're going to deliver, because when you take this balloon out, what you want is a better Bishop score. You want more. There should be some dilation. There should be some effacement. It should soften the cervix. It's just over time. And if you get those changes, your next step, if the person is not now in their own labor, is to start them on Pitocin. So how likely is that Pitocin to work? Depends on the cervix. If the cervix is still, you never got any dilation with the balloon. You deflated it and took it out, and the cervix is still 1 centimeter dilated, and it's still thick and long, and the baby's head has not come down, and you're still no at all close to vaginal delivery. I can tell them at that point, this may be a point at which you want to say, I don't want to go to the next step. This may be a point that I feel Pitocin is not going to work very well. So my advice would be, if you're not looking for like the long haul, now we can throw the towel in, so to speak, and go for a C-section, but they don't have to. Sometimes you take the balloon out, they've got a much better Bishop score, better cervix, softer, they're starting to contract on their own, put them on a little bit of Pitocin and slowly turn it up. It's like a crank, little by little by little, and at all that time, watching for a category of tracing, because now once you start Pitocin, your intention is strong, regular contractions with enough frequency and strength to dilate your cervix more. So depending on where you start, that's what you're going to expect later. If they're still really, really early and you start very, very low dose Pitocin and go up very slowly, 12 hours later, you could be 2 centimeters dilated. So this is where all the decision making comes in. If things are moving along and the baby's fine and there's no rush and you're still in the 39th week, so there's good placental reserve, there's no meconium, you don't see anything suspicious on the tracing. If the patient wants to keep going and things are okay, they keep going. And this is, of course, where problems can happen on the physician side, because in my hospital and in most hospitals, when someone's a VBAC, someone has to be in the hospital while they are laboring. Sometimes it's only when they're in active labor, but sometimes it's the whole labor time, because at any point, you could have no warning whatsoever. You could have a uterine rupture, or you could have a terrible tracing, and you got to rush to the OR. Somebody has to be there. And this can definitely figure in, I'm not saying like doctors are doing it for their own convenience or they're lazy or something, but if they really don't think somebody's going to be successful at a VBAC, and this is going to be like a 30-hour balloon and then induction and then Pitocin and everything, somebody has to be there. So it does make them a little bit more anxious. And of course, this has all to do with how are they explaining it. They don't want to say, you shouldn't really say, it's too long already. That's not a reason, right? If everything looks fine and that patient wants to keep going and this was your plan and you talked about it, you're obligated to continue while still reassessing the situation and telling them as time goes on, I'm losing faith that this might be a successful VBAC, and you may want to switch and have a C-section before we get to a point. Because I can tell you, the worst in the world is go all the way through the labor, get to completely dilated, pushing and pushing and pushing, and then you can't get the baby out. If you could have anticipated that before that point, please go have a C-section. It's so hard. But that's why constant reassessment is really important. And how do you know that you might think that could happen? Maybe that's what happened last time. Maybe this person got to fully dilated and they had a 6-pound baby that was in a good position and they pushed for 4 hours and they ended up with a C-section. Now here you go again. Who wants to do that twice? So That's really the point.
Hopefully nobody.
I hope nobody, because I don't want to do it either. But it's really true. It's so important to reassess as it goes on. I've heard definitely complaints from people who go, yeah, my doctor just walked in and said, okay, that's it. We're having a C-section. No explanation, or she thinks there's no explanation. There's so much explanation. Look at the tracing. Now you have meconium. Now you have a fever. Now, whatever it is, if you're now going to do it because of a real reason, not just failing to dilate enough, then it becomes emergent, and that's when babies end up in the NICU. And that's where people say they were sorry they ever did that. I think everybody has to be aware of what the outcomes could be and re-aware of that as the whole process goes on.
Okay, question about VBACs and epidural versus no epidural. Why not? Does it really make a difference to the patient? Does it make a difference to you?
Well, I love epidurals in general, not because it makes my job easier, but because I've delivered over 1,000 babies and I can tell you 100% who's happier, people with epidurals. Mostly because if you look at the reason why people forego epidurals, it's almost 100% myth. They think it's bad for the baby. I should feel the contractions. That would be better for me. I'm not a real woman who delivered really if I didn't feel my contractions. Epidural will give my kid autism. All the things that are the reasons why they don't want to get an epidural are not based on science. So that drives me a little nuts. However, if there's somebody who says, I don't want an epidural under any circumstances, I do ask why and try to correct the myths. But there are some people who just feel like that's not for them, and that's fine. But in general, it makes your birth experience a lot happier. So with a VBAC, the reason I doubly like people to have an epidural is, number one, you've got a scar in your uterus. So your contractions are likely to hurt more than somebody on an unscarred uterus. So they're painful. So I don't want to see my patients in pain. But also you have the added benefit that if your epidural is working really well, God forbid something happens during the labor, you rupture, you have a big deceleration, some emergency where you have to rush and go do a C-section. You don't have to go under general anesthesia. They will use your working epidural and just dose it up and do the C-section with the epidural. If you don't have an epidural and we go for a big emergency and it's really an emergency, I need to get that baby out right away, you're going to sleep. And nobody really should want to go to sleep. I mean, I've had a few people say, please put me to sleep and take the baby out, but that's really rare. And it's not good. You want to talk about something that's not good for you or the baby? You don't want to have emergency general anesthesia. One, you might have eaten or drank something while you were in labor, and now you're at risk for aspiration. Two, as soon as you get general anesthesia, it goes right to the baby, and you've got to get that baby out right away, and most babies come out very groggy. And three, you don't get to see your baby right away. So when somebody tells me they want a VBAC and they don't want an epidural, that's one of the few instances where I do push. I really try and talk them into it. You don't have to have it from the minute you walk in. I understand people want to walk and, be active and whatever. But once you're in active labor, walking is really not fun. So you don't really have to walk when you're, screaming. You should be comfortable, get into whatever position you want. Let us monitor the baby and let's do the Pitocin and get you to your VBAC if that's what you want.
Yeah, that's the other thing that people say, which, oh my gosh, there's so much confusion on this point, is that people say, well, if you have an epidural and you rupture, you won't feel it, which actually is the opposite of what happens.
Right. You'll see.
Can you explain the pain of a rupture to us?
The pain of a rupture is a different kind of pain because if you have uterine rupture, it doesn't just stay down below the belly button, which is basically where the epidural works. You've got contents coming out of your uterus into your abdominal cavity. Your liver is going to be irritated. Your stomach, all the upper organs are irritated. You will be in pain and the baby immediately loses oxygen. We will see it on the monitor. Now, I can't say 100% every time I've picked up a rupture the moment it happened because ruptures can happen really at any time. People always ask, when's the most likely time for somebody to rupture? Probably active labor that's prolonged is a time to rupture. But have I seen it in the very beginning? Have I seen it before somebody went into labor? Absolutely. So, I don't think that's a valid reason for someone not to have an epidural. I think they're more likely to fail because they're so uncomfortable that they can't take it. And then we throw the towel in than we are to mask a rupture that we miss and somehow don't save the baby from. Like I said, doctor has to be in the hospital. Anesthesia has to be in the hospital. The monitor, you can't intermittently, I do a lot of intermittent monitoring for some of my patients who go in, not for VBACs. So, it's a different animal. You have to be aware. And I feel like the out of hospital community feels like, oh, it's just a mother method of birth. It is not.
No, it's not at all. I've actually noticed a lot of people on VBAC, like a lot of people on VBAC for some reason think, oh, my water breaks, I'm not going to go in. And I'm like, no, you need to go in. Like, or I'm just going to wait till I'm, at a couple minutes apart. And then I'm like, no, if you're noticing labor signs, or your doctor should have already told you like what these labor signs of go to the hospital.
That should have been part of the
Yes.
Right.
Yeah, like all of that needs to be like there. Like I remember actually, even though I was having a planned C-section, I was given a sheet of paper to remember because, pregnancy brain, you don't remember everything. They were like, put this on your fridge. If you notice this, this, or this.
Right. Right.
Yes.
Right.
They were like, you notice this, go in, because it means you're in labor. And I was like, I'm in labor. Like in my mind, I'm planning a C-section. They were like, you can still go into labor and we'll just go for your C-section. But I feel like so many people like, oh no, I'll just wait. Don't wait. You're planning a VBAC. Please don't wait. Just go in. Like, don't wait. You need to be monitored.
Behind doing it in the 39th week, if you want an elective C-section, is so that you don't go into labor. But, anyone can go into labor at any time. So if you labor before your elective C-section, people go like, wait, will I still have to wait? I'm like, no, show up. We see you're in labor.
I actually asked my doctors, because I ended up with a specialist and an OB, and I asked them, I was like, if I go into labor while I'm planning my C-section, am I going to have a VBAC? And they laughed and they were like, no, you'll still have a C-section. But I was like, oh, okay. Because we need to talk about that. I'm not prepared.
Yeah. The one, I don't know if you read the one article that I wrote about. So they called me at 4:00 in the morning, somebody was writhing in pain in the hospital. And I took one look at her. I was like, you're rupturing your uterus. Let's go in the OR. And sure enough, baby was hand out, Oh, yeah.
Yeah, that's the one thing about the idea of having an out of hospital VBAC is just terrifying, because if the doctor and the anesthesiologist have to be right there in the hospital with you the whole time, the idea that and midwives are terrible, honestly, about saying, oh, we'll be there every step of the way, and then they'll just assess you over the phone and say, oh, when your contractions are getting closer, let me know. It's like, well, no one's monitoring you. You're alone. You don't know what's happening. Nobody knows what's happening.
The crazy thing is that if you do have a successful VBAC at home, the answer to us is, you see, I knew you could do it. When our answer is, man, you're damn lucky. That's, it's a completely different point of view, how to look at it.